everyone. Thanks for joining us here. And all the way from the UK, let's welcome Dr. Adam Stern. And Dr. Stern is no stranger to us. Dr. Stern has told us in the past about medicine and really guided us in many ways. So let's welcome Dr. Stern for screening in medicine. Is it friend or foe? And then the doctor will take all of your questions, as well as discussing what is useful to include in a health check each year, followed by whatever questions you want. My first question is, how do we survive winter? But I guess he'll talk and tell us what we need to know. Dr. Stern, the floor is yours.
Okay. Thank you very much, Rabbi. And it's so nice to be able to speak with you again and have a chance to interact with you guys. I really enjoyed the in-person sessions that I did in the earlier part of the year with you. And so I wanted to, we had some nice conversations and really some interesting areas that we discussed. And so I was thinking about continuity and really continuing to open up this space for considering, important medical areas, sometimes with some ethical, aspects to them, and to have a flow of this kind of interaction, thoughtfulness, and for us all to be, more informed, and as well as you hopefully learning from me and the thinking that I put into this. I learn from you. I learn from your thoughts and your interactions and your questions. So I wanted to, I was thinking, right, what's going to be a nice, juicy, interesting subject to begin with? What should, and I want to know, can you hear me okay? Is my voice clear? Can you see me and hear me? Can you put your hands up if you can hear me?
We hear you and we see you.
And you see me, okay. So what's happening? Okay, so I'm going to want to scroll down my slides, and so you may need to help me with this when we go a little bit further, Rabbi. Okay, because I think it's stuck on the first one at the moment. Okay. So I chose the subject screening in medicine, and this was always one of the subjects from the time that I was beginning in medical school. This was always often a subject that we were discussing. It's what is a valid screening test? What should be screened for in the population or in subsets of the population? And so if I'm thinking as a little boy, I'm thinking, well, everything should be screened for, really. We want to be as healthy as we can, and why not just get a whole load of screening programs out and then find out and diagnose illnesses earlier, and then people can have happier, longer, better quality lives. Unfortunately, the world doesn't quite work like that, as I'm finding out, and as we find out, and there are several things to consider in a screening test. So I thought one thing that really speaks to me is the duties of a doctor. So we learn this from early days in our medical school, and there are a few tenets by which we must work. So we look at the letters for the different areas are A, B, C, and D. So that's one way of looking at it. So A stands for patient autonomy. So we should encourage the patient's own choice and autonomy wherever that is possible, include patients in decision making, all of that area. B is for a beneficence, which is to do good. We need to do good for our patients. C is patient confidentiality. It's important that if there are sensitive and personal
Sorry, Dr.
things.
Stern, do you have slides for these that you're able to?
So I don't have the ABCD on a slide. I have the ABCD in my mind. That was an extra bit that I added on. So I'm just gonna. So not for the ABCD. I can provide it later, but that will. But I just wanted to say, by way of leading into this subject really. So C is patient confidentiality, and D is do no harm. So particularly B and D, beneficence, do good and do no harm, are relevant when we're thinking about screening. And and in the Jewish faith, there is in our Jewish teachings, we're in the world to do good for other human beings, to do good for each other. So that's important also, I think, from the religious perspective. What do we do to do good? So that's by way of introducing this this area. So I want to get on to the next slide, Rabbi, but it's I put it on slideshow. How now can I get onto the next slide?
Click next or use your mouse to scroll.
Okay, so that is where it's, because I don't know, put it on
There you go.
slideshow. It's not scrolling.
You just gotta click with the mouse.
Okay, so now next. Okay, that's great, thank you. Okay, that's great. All right, so thank you very much. Okay, so screening is a way of identifying apparently healthy people who may have an increased risk of a particular condition. And finding out about the treatment early can mean that the treatment is more effective. Okay, so this is important. Characteristics of a good screening test. So particularly the last one. So we've got validity. It distinguishes diseased and non-diseased people. So that's really important. And then some other things that are important to consider are that it's consistent. So you don't want an inconsistent test that's sometimes positive on one day, and then the next day it's not positive, and then positive the following day, and then that's no good, because you can't rely on that. And then ideally minimal discomfort, easy to administer, and inexpensive. So cost is an important factor if you're in the whole setup, but particularly that validity. And in screening, the concept of false positives and false negatives come up. So this is really important in screening. So false positives are the number of people who are screened who come with a falsely positive result. Okay, so and false negative, you don't really know negative, you're screening somebody and the result comes up as a negative when it's not actually negative. So if you've got false positives, then you will be very, so you get a positive, and then patients or people will have unnecessary tests and investigations with the cost and discomfort and all the not nice things that come from that. And falsely negative is not good, because that gives a false reassurance. And the thing is that actual screening typically fall short, and sometimes far short of these ideals. That's a real nub of it and a real problem. So we'll go on to the next slide. Okay, so what I've done, I brought some examples from the UK. The UK is where I trained and where I've worked. So obviously that's my background, and some things in South Africa will be a little bit different in terms of tests that are done, but the principles are still the same. And in the UK, we've got a nationally funded health system called the National Health Service, and that has been a powerful system in the UK since after the Second World War. And so in latter years, there are more strains on the National Health Service, but pretty much that's been the mainstay of the provision of health in the UK since the Second World War. And there is a committee, it's a UK national committee that advises on screening programs. So they're very aware of the criteria, the characteristics of a good screening test that we mentioned above, and particularly, also including that, well, certainly reliability, consistency, but also the cost effectiveness on a whole population will certainly come into their thinking. Okay, so what I've done is, okay, so the UK screening, there's a committee, they review their policies every 3 years in terms of screening according to they research the evidence, they look carefully and look at the tests that reach the threshold of those criteria for being allowed as screening tests. And actually, in terms of regular screening tests in the UK passed by this committee, there are not very many. You may think that you'd screen for all kinds of things, but there are not very many. So so these slides that are coming up are quite busy. I didn't, I kept the details on them, and you can just see the current tests that have the go-ahead, the current screening tests that have the go-ahead. So there are several tests in pregnancy. So that's the list of the tests in pregnancy. Then we'll go on to, okay, so let's come back. Sorry, let's go back. Now I want to go back a screen. Is there, I don't want to go forward, I'm going forward now. Sorry, that's going forward. Rabah, any clues as to how I go back a slide? No? Okay, previous, there we are.
Just go backward.
Yeah, that's great, thanks. Okay, so screening in pregnancy, and I want to go, gonna go down. Okay, sorry, apologies. Okay, I'm gonna tell you then. I had a list of the various tests that are screened for in the UK. Okay, so I'm going to tell you several ones screening in pregnancy. There are several screening tests in newborn babies. So there are various things that are tested for, and really on a population level, there are not many screening tests that are done. So in women between 25 and 64, I think it is, there is cervical screening tests. That's to screen cervical cancer. So that is one of the screening tests that has been in utilization for lots of years now, maybe 25, 30 years. And it qualifies for those criteria. So that's in the UK. We've got the cervical screening test, and we also have breast screening. So in the UK, on population level, it's women aged 50 to 70 have a mammogram, and that is not done earlier than 50 in the UK, partly because the breast tissue is denser below 50 years of age, and mammograms are not sensitive, are not so sensitive. Okay, and then about, I think something like 10 years ago, there was some, there's a bowel screening test. So for people aged 60 to 74, there's a poo test. You get it, sent it in the post, you send a few samples of it, little samples of your feces, and send it off, and then that's screened for blood. So that one is going. Now there's from men over 65, there is an ultrasound scan done for abdominal aortic aneurysm screening. But you see, there are not many screening tests that are done as a regular thing in the whole of the population. There's going to be an additional one for certain people with certain symptoms. They're going to do CT scans for lung cancer. But I suppose I just wanted to go through that to show you that there, I think overall, in terms of things that you think may be screened for, there are not that many things that are screened for on a kind of population or part of the population level. So what I wanted to do, so I'm going to go into some particular conditions that I would have thought wow, they really would be screening for that, and they're not. And there are reasons why they're not screening for some of those. But I wanted to know from people who are in the audience, do you have any thoughts at this time? What are your thoughts? What are your considerations on this? Any questions about it? What's it stirring? Yes, I'm sorry, tell me your name. I can only see you as a small person. I do recognize you. What's your name?
Renee.
Renee, okay. Yeah, Renee. Okay, so that I think the question will need to be repeated because I couldn't hear what you said. Can you hear me? I've just lost, so I didn't hear the question, Renee.
Question is it necessary?
Sorry, so I just missed that.
Okay, we're back.
Okay,
Doc, did you hear the question?
I didn't. No, so if you could repeat that, that would be great.
Okay, we're back.
Okay.
Did you hear the question?
I didn't.
Go ahead.
No.
Renee. I think there's a delay between Joburg and London.
Oh, I'm sorry.
Okay, go. Try again, Renee. Try again.
I'm sorry, I didn't.
Okay. First part of the question that Renee's
Yes.
asking is it necessary to have a colonoscopy?
Does Renee, do you mean for everybody in the population at a certain age without symptoms? Is that your question? So I think that is an area, certainly in the UK, that they are working on. So I think it would be, so it hasn't yet come into a regular screening program. So it's not like everybody is going for a colonoscopy at a certain age. I think it would be a nice thing to be able to have. And they were rolling out sigmoidoscopies, which is a partial colonoscopy. It looks at a part, at one part of the colon, not all the way around. And they were going to do that in some areas of London. So I know from the obviously the UK context, after over 55s. But I don't think, and I think COVID stopped that momentum, and I'm not quite sure where they are in that process at the moment. So I mean, none of these are a bad thing to have a colonoscopy, but I can just tell you from the UK perspective, it's not yet in one of the screening programs. So remember, like in the UK, it's government funded money, so they just have to show evidence on a population basis that it's cost effective also to do that. But on an individual level, it would never be a bad idea to have one. Does that answer your question? Is that helpful? So I didn't. Your voice just tailed off at the end because sorry. So Rabbi or somebody else will need to repeat the question. Apologies for the transmission of sound.
If a person had a hysterectomy, do they need to have pap smears or any other?
Okay, so if you've had a hysterectomy, it depends how much they've taken out. And so if the cervix has come out, then you don't have to have pap smears. But that is a question for your gynecologist or your GP, because some people have had a hysterectomy, do need pap smears, other people don't. Depends how much has come out. So if there are any of the cells that are retained inside the same cells of the cervix, then you'll need to have a smear. Is that clear? Okay, cool.
Any other questions?
And any other thoughts on the presentation, on screening? I thought it was a good subject to stir people into like, yeah, you should do this or you shouldn't do this.
Yeah, we got a question from Rosemary. I think there's a communication barrier between here and there. It's the internet that's weak today. We'll have to use God, there'll be stronger internet soon here.
Yeah.
Maybe continue with your presentation because I think questions are struggling.
Okay, that's fine. Hopefully we'll stir some thoughts. That's the part of the aim. All right, so I then have picked out some conditions which are not screened for on a population basis, but I would have thought, my goodness, shouldn't they be screening for those? But they're not. So I'm going to go forwards and I'm going to talk about a few of those conditions. Okay, so there's a condition. Can you hear me okay? Just put your hands up if you can hear me okay. Okay, so there's a transmission from, so there's some transmission from London, that's good. Okay, so all right, so there's a condition called atrial fibrillation where your heart beats irregularly. And if you have if there is atrial fibrillation, then there can be an increased risk of sending off clots and also strokes. There's an increased risk of strokes, not a huge increased risk. So I would have thought, so if you're going to screen for atrial fibrillation, you want to go, you have a screening program, you need to feel somebody's pulse, you need to listen to their heart, essentially, the rhythm of their heart. So you would think, yeah, that's a great thing. Let's get up a screening program to do that so you can prevent people getting these complications. But the committee in the UK has looked at it and they've looked at different types of atrial fibrillation, and it's not clear if they all have the same risk for stroke. It's not known how effective treatment for atrial fibrillation is in people found through screening. It's not known if screening is more beneficial for people than atrial fibrillation than the current approach. So there are lots of caveats and lots of nuances in this. So atrial fibrillation is currently not screened for in the UK. So it doesn't mean to say, you know, if you have a patient coming into your clinic, it's a very good thing to feel their pulse if they come for something else, and to listen to their heart and make sure that's all right. But this is on a population screening basis. And then bladder cancer, I would have thought, you know, that's a relatively common cancer. You would have thought that there would be good to screen for that. But there's the recommendations that it's not recommended because there's no safe, precise, and valid screening test for bladder cancer. So there we are. That's really makes you think. So I'm just gonna go forward. Okay, so lung cancer, as I mentioned, that is gonna there's going to be targeted screening for people 55 to 74 identified as being at high risk of lung cancer. So, and they're going to do screening with low dose CAT scans, CT scans. Okay, so then oral cancer, I think this is interesting. Population screening for oral cancer is not recommended for several reasons. Firstly, oral cancer develops from abnormal tissue in the mouth, but only 5% of abnormalities become cancers. It's not possible to predict which ones will become cancer and which will not. And there's not enough evidence to know how well existing tests would perform in a general population. And finally, it's not clear what the best treatments to use in people are where there's something detected with screening. Okay, so then this is like a big one. Often people in terms of lifestyle medicine, including women when they come to the menopause, but there's lots of talk about, and we talked about it when we were doing the discussion on exercise, about weight-bearing exercise, balance exercise, which help the strength of your bones. But so we're looking at osteoporosis, thinning of your bones, and it's not recommended to screen in postmenopausal women. Because they say it's not known how accurate screening tests are in women who would be screened. It's not known what effect treatment and changes in lifestyle would have on some types of fracture. It's not known what effect treatment and changes in lifestyle will have on women identified as being at risk of fracture through screening. And research shows that screening all women does not reduce the number of fractures compared to current care. So I put some of this in red that I thought was particularly interesting. So that makes you think, because, yeah, that makes you think, certainly in terms of osteoporosis. Prostate cancer, so that's quite a big one. There's quite a lot of discussion about prostate cancer in men. And then there have been pushes, certainly in the UK, to maybe screen everybody with the blood test called PSA. But the current recommendations are not to do it because the PSA is not accurate enough to detect prostate cancer that needs treatment. It can falsify men who do not have prostate cancer. It can also miss some cancers. So we're talking about some false positives in the test. This means that many men may have to undergo unnecessary and often unpleasant tests and or unnecessary treatment. So we want to avoid that. So it's not so straightforward. Okay, and then there's a bit more on prostate cancer. So I won't go into this slide. That's more detail on prostate cancer. Ovarian cancer. So this is a very interesting area. Ovarian cancer in women is one of the cancers. So ovarian cancer and pancreatic cancer can often present with non-specific symptoms that can mimic other things. So it's a more difficult thing sometimes to diagnose. But the recommendations are not to screen for ovarian cancer. Okay. In the trial that they did, screening did not reduce the number of women who have died from ovarian cancer. But they're continuing to do trials looking at whether screening would be brought in for ovarian cancer. Okay, so let's go back. Okay, we're going forward, so let's go back. Okay. Okay, so any thoughts on that? I thought those examples were interesting, thought-provoking. Does it spark up any questions, any concerns, any Any disagreements with what you've heard? Yes. Renee. Okay, so
Yes.
okay, so we may need some translation. So that got lost in translation, as in I couldn't hear that, I'm afraid. So
Repeat.
yes, please, thank you. Okay, I'm really sorry, Renee. I can't actually. So I can't hear you, Renee. So I'm wondering, Rabbi, if it would be possible to repeat the question. I'm sorry that I can't. Otherwise, I can't hear it.
You know what? I think next time I'll try to get a microphone or something to fix this up.
That's great. Sorry, could could you possibly repeat the question, Rabbi?
When something is not symptomatic, how does
Yeah.
one know to go for tests?
That's a very good question. So that's the whole kind of ethos and area of screening, and so we're really looking at the what's covert and what's revealed. So once you have symptoms, then that will direct you to go for tests. So we're really looking at so in a way, that's what this whole area of screening tests is looking at. So these would often be for asymptomatic people. So for example, in the cervical screening program, people will not have symptoms mainly, and they'll go and have a cervical smear done. And then so those are recommendations, or people will go for mammography, that's recommendation, or people will go for their bowel cancer screening so certainly through the poo test. So that's really what we're looking at. And we're looking at the tests that would be recommended. So one of the things I thought that we would talk about today is, on an individual basis, if you're otherwise well in yourself, what is good to have tested, say, every year? I was just thinking through that. That's a question. So does that make sense as an answer? Is that enough of an answer to the question?
Repeat it.
So I'm not getting enough voice from people who are sitting in the audience. So I'm sorry, Rabbi, I think you'll need to repeat the questions.
Okay, she's asking that are these routine tests that women generally go for?
Yes, they are. So they would be routine tests. Yeah, routine screening tests. So I think we've got a differentiation. We've got a differentiation from a population-based screening, and on an individual basis. So as an individual, then even if you don't have symptoms, there may be other factors that would determine your considering going for other tests. So for example, if there's a family history of a particular illness that's going through your family, that may give you a lower threshold to have a test. So for example, if there's a family history of diabetes, strong family history of diabetes, or if there's a family history of certain types of cancers, then screening for that particular cancer, that may be advised. But that's a different thing. So each individual needs to consider their context and their setup and their things like their family history. But we're talking, all population-based screening also. Any other questions in there? You guys are much smaller than when I was there.
Okay, Eric has a question.
Okay, hello, Eric.
How often should a male go for a colonoscopy?
Okay, so that's the same. That is the same, a similar question to previously about a colonoscopy. So it depends if you're otherwise well, then in the UK context at the moment, so obviously it's South African context is a little bit different. There would be no need for a colonoscopy if you're otherwise well, no other risk factors. But in South Africa, I mean, that's to discuss, because that hasn't actually gone qualified for screening tests in the UK, but in South Africa, that's a question for your clinician, really. So if, say, you were otherwise well and you had a normal colonoscopy, I don't know, they may want to repeat it in a year, they may want to repeat it in 2 years or 5 years, but that's really just to get that determined with either your GP or your gastroenterologist, or colorectal doctor. If you've got symptoms, that's different. Then that's judged according to the symptoms and the tests that are required to find out what's going on. Is that a clear answer?
Thank you.
Is it clear? Okay, good. I want to make sure. It's clear. Any other thoughts? Any other questions? I see some movement. No?
We're all ears.
Oh, you're all ears. Okay. So then I thought, then I had a thought, and this is not written in this is not set in stone at all, but it's just my own thinking about, so if, say, somebody came to me who was, say, 70 or 75 and was otherwise well in themselves and no concerns, what would be some reasonable things to monitor, say, each year? So what would be, so this is what I thought, and so there we are. I said it's not set in stone. I think it's very important sometimes to say things, things vary and it needs to be nuanced a bit individually. However, okay, so what I think it's actually quite nice to come in and see a clinician or your healthcare provider, and you can do an awful lot in 5 or 10 minutes of just asking a history, taking history about somebody is, particularly in just what we call the activities of daily living. So that's how you're getting around, how you're moving around, what's your balance like, what's your strength like when you're moving around? How can you walk? How can you move? How are you eating and drinking? If you excuse my phraseology, how are you pooing and peeing? You know, those are important questions. If you have any particular shortness of breath, and that's really that's kind of most of it in terms of just the basics of how you're functioning in your day. But I think it's nice to do that and to have some just asking those questions, because in what we say in medicine is that actually often 80% of the diagnosis of what's going on is actually made through the history. So you may think, oh, you know, you have to do so that's from early days. It's the accuracy of the history taking, the asking the right types of questions, and then that will direct you if there are any problems. So that's what I would suggest. And in terms of things to check, I would say it's not a bad idea to check a pulse. We said that a population screening for atrial fibrillation for the irregular pulse is not done in the UK at the moment, but I think it's helpful to check the pulse, blood pressure, listen to the heart and chest, examine the abdomen, just a basic hand on the abdomen. That's what I would say. Okay, so that. Oh, whoops. Okay, so okay, how are we doing on time, Rabbi? So we're 40 minutes in. Can you hear me?
I think we could we should wrap up for today shortly.
Okay. All right, so that's the presentation. Any do we have time for any other thoughts, questions, or are we going to wrap up?
Waterborne diseases is the question. What's your question about?
Okay. All right. So
Okay, the question is waterborne diseases. There are certain municipalities here in South Africa where what's the matter about the waterborne, like cholera? Well, particularly cholera at the moment is a major concern.
oh, okay. Yeah. Okay, so is that a point or is that a question?
It's a question. What's the question?
What's the question?
Question basically is how to safeguard oneself from waterborne diseases.
Okay. Well, there should be some. I'm sure there will be some local guidance, like with the E. coli stuff that was in the water near Umhlanga. So that there should be local guidance on measures to take in terms of waterborne diseases, but things like, you know, cholera, just being really careful about what you're drinking, about the purity of the water, about having bottled water, you know, proper bottled water, all of that kind of thing. But I think that the detail of that advice should be quite easy to kind of find online in terms of the relevant areas, in terms of the specifics of the advice. So I mean, that's just a very general answer. I can so for the next time I can tell you a bit more about that, if that's going to be helpful. Would that be helpful?
Saying yes.
Okay, all right, so we'll do something on waterborne diseases. Okay, all right.
I'd love to talk about winter, getting through winter.
What do you want to know particularly about getting through winter, Rabbi?
Tips and tricks.
Hints and tips. Hints and tips. So what's, no, seriously. So I mean, obviously, like in the northern hemisphere, we have cold winters here, but we do have heating in the houses, which makes quite a difference. No, but okay. So do you have a particular query about winter? No, seriously, like a particular concern or a particular area?
Just how to get through this cold, you know,
The cold.
young and old, but you know, it's cold, it's bitter.
Yeah.
People are getting shivers.
Yeah. Yeah, of course. And it's more difficult in that you know, the houses are not heated. So I mean, yeah. Let me see if there's anything more than the obvious things. So I mean, you know, the obvious things, of course, you know, wrapping up warmly, you know, lots of layers, moving around a bit, you know, having like enough, making sure that you're having proper nutrition, having enough hot meals. You know, that's the basic stuff. But I mean, that's what's immediately on the top of my, but you know, that's the kind of basic stuff. Okay. I'll have a think about that, see if there's anything else that comes up specifically. Okay. All right, so.
All right, I think for today, we're going to say thank you, Dr. Stern. We're very grateful.
Okay, thank you. So, thank you. And I thought for the next time we can maybe do IBS. Okay, thank you. Thank you. Thanks a lot, everybody. Nice to see you again.